Hello and welcome to this RPTH research recap, where we dive a little deeper into the science being published at RPTH. My name is Matthew Cormier, and I'm currently an associate editor of social media at RPTH and a PhD candidate at Queen's University in Canada. I want to thank you all for tuning in today. And as always, just a reminder for everyone watching live, please feel free to leave any questions that you may have for our two speakers today in the chat box down below, depending on what platform you're watching it from, and we will get to them during the discussion period. Now, with that being said, today I'm pleased to introduce our two speakers who will be talking to us about their interesting findings regarding iron and platelets in women with iron deficiency anemia. Now, firstly, Dr. Schatzel is an associate professor and hematologist in the Division of Hematology Oncology at the Oregon Health and Science University. He is also currently the co-director of clinical research in the Department of Biomedical Engineering. His research interests center around iron physiology and the development of novel strategies to improve outcomes for his patients. Now, Dr. Jamie Lowe is an associate professor in OBGYN in the Department of Obstetrics and Gynecology in the Division of Maternal Fetal Medicine at the same institution, as well in the Division of Reproductive and Developmental Sciences at the Oregon National Primate Research Center. Her research interests involve studying the impact of environmental perturbations on placental function and offspring development using non-human primate models. Now, Dr. Schatzel and Lowe, we look forward to hearing your talk.
Thanks, Matt. Good morning. Okay, well, thank you everyone for joining today's talk. I want to go through our work. The paper is entitled Platelet Reactivity and Platelet Count in Women with Iron Deficiency Treated with Intravenous Iron. We have a very large team of collaborators who I'm thankful for. Some background. Iron deficiency is just way more common than one would think. It impacts 1 in 5 premenopausal women in the world. That's a powerful statement if you think about it. And we really were interested in how it impacts platelets and hemostasis. So it's pretty well described that iron deficiency causes an increase in platelet count. But what is not well described is how it impacts the platelet function. And that's really what we hope to answer from this question, from this study. So our objective, first we aim to describe the impact of iron repletion with IV iron on platelet count, and we focused on premenopausal women with iron deficiency who we were treating in our clinic. And then we devised a simple study where we collected blood samples before iron in the iron deficient state, and then a few weeks after iron in the iron replete state. And we wanted to just see how the platelets functioned in both states and if we could discern a measurable difference. So here are essentially the two studies we performed in this publication. First, we wanted to confirm that this change in platelet count was seen in premenopausal women. So we did a retrospective study of women treated at our center, and we found 231 individual subjects who qualified. And then to do the platelet function analysis, we performed a prospective study where we collected blood samples before and after IV iron. And in that study, we did 13 subjects. So the main cause of iron deficiency in both cohorts was heavy menstrual bleeding. Some patients also had undergone bariatric surgery. And you will see that there was kind of a spread of the phenotype. Iron deficiency without anemia was 30 to 40% of patients. Then iron deficiency with anemia was the most common. And then we had a small amount of patients who had iron deficiency anemia with thrombocytosis. And the mean ferritin in both group was quite low. Before iron repletion, 14 in the prospective cohort and 11 in the retrospective cohort. So the first thing we did is look in the retrospective cohort, and we wanted to confirm that platelet count did change with iron repletion. And we did find that actually. The mean platelet count dropped significantly after IV iron. And as one would expect, the mean hemoglobin increased. We looked at the same indices in our prospective cohort. If you look at panel A here, you see just how effective IV iron is. It's really refreshing to see that the majority of subjects had a very robust response in their ferritin. We had one non-responder. But we also found the exact same outcome as the retrospective cohort. The platelet count did decrease significantly after IV iron, and the hemoglobin significantly increased. Now we wanted to look at how the platelets functioned before and after the iron. So does iron deficiency change the function of platelets in some measurable way? And is that reversed with iron repletion? So first we did flow cytometry. This is FACS. And we exposed the platelets to various agonists. You'll see at the bottom here, we have resting platelets, some exposed to CRP, ADP, etc. And we're measuring for integrin activation or alpha granule secretion, essentially PAC1 or CD62 expression. And we actually did find a significant difference in alpha granule secretion after IV iron. And this kind of suggested that the platelets in the iron deficient state are a bit, as the literature terms, exhausted. And this was reversed after IV iron. Then we tried to do some more translational assays. We took whole blood from each subject and we flowed that over collagen. This is a microfluidic device our lab uses quite often. We flowed it at venous rates. And you can measure just how well the platelets aggregate on this collagen surface. And after iron repletion, the surface coverage was significantly increased. Just suggests that the platelet aggregation was much measurably higher after IV iron. So that's the key points of the study. Before we open for questions, I just wanted to close that if anyone out there would like to collaborate us, we're always interested in postdocs or new fellows to come to our clinical training programs. We have a 1-year hemostasis thrombosis fellowship in our program, and we love to collaborate. And you'll see that both myself and Dr. Lowe, our emails are linked below. So feel free to reach out. And thank you. Sorry, Matt, we're having trouble hearing you.
Thank you.
There you go.
Thanks again for that presentation. Now that it is discussion period, I do have a couple questions for you, but if any of the audience members would like to ask a question, please feel free to leave them in the chat below. So the first question is maybe a bit naive or simple, but so what are some symptoms of iron deficiency anemia? And I'm interested, how soon after you replate with intravenous iron do you see some correction in these laboratory parameters, as well as some of the symptoms that might be associated with the anemia?
Yeah, that's a great question. And I think I'll tell you my experience as a hematologist, because I give quite a lot of iron. The main things I hear from my patients are fatigue. People just feel tired and they feel run down. They notice something's off. And I get a sense that patients can develop these symptoms even before they're anemic, and the literature has somewhat confirmed that. We kind of call that latent iron deficiency, where the iron is low, but the blood counts all look fine. Certainly iron deficiency anemia, particularly if it's severe anemia, people are very run down. The other symptoms that people can experience are hair thinning, restless leg. Sometimes they get a urge to kick their legs at night. I've had patients get a strong desire to chew on things like ice too, which also is reversed when you replete their iron. I don't know, Jamie, if you want to comment. I mean, I think in your practice, you're giving it more often to pregnant women.
Yeah, I was just going to say same symptoms, but a little more profound, I would say, and patients tend to be more symptomatic with it. either during the pregnancy or postpartum after they deliver. Restless legs is very common with it. Eating ice, dirt, that kind of tendency, which sounds odd, but happens, especially in pregnancy. It's more common. And definitely, that extreme fatigue, it's often hard to sort out between, is this iron deficiency? Is this just pregnancy hormones? But often, after they get IV iron repletion, within a week or two, they symptomatically feel so much better. And this is tremendous, especially postpartum when they're caring for their newborn, and it helps them with feeling less dizzy, feeling more energetic, able to make it through their day with all their challenges.
Yeah, people just feel better when their iron is in a good space.
Yeah.
The other thing I found is a lot of patients are treated with oral iron. It's very accessible. You can get it at the grocery, but it's not very effective. I have had some people successfully get their iron levels up with it, but I've had a large portion of patients come back, say it's not working. We give IV iron in that setting, and it works pretty rapidly usually.
Oh, that's good.
Yeah, it's definitely life change or a game changer for pregnant women during the pregnancy in the third trimester or postpartum. Oral iron just, takes a couple months before they can get to that point. They're also, eating the best diet because they've got a newborn.
And from a personal interest standpoint, is that have to be re-administered after several weeks? What is the time frame like for that treatment?
Yeah, that's a great question. So there's a lot of different ways that iron can be given IV. Sort of the older way that was used more commonly when I was a resident is to use a low dose of iron over several visits. Iron sucrose being the most common one. These days in my practice, I've pretty much gone to these high dose single visit irons. So I'll give the iron used in this study is our standard in my practice, and it's 1,000 milligrams of low molecular weight iron dextran, just given once. And that dose, for a vast majority of patients, will correct their iron deficiency. And generally, depending on why they're iron deficient, it can last a year or more. Everyone's a little different, though. People who are like severely iron deficient and who are still losing iron at a brisk rate will need it more often.
And then in pregnant women, we do the older dose or the older method, which is the smaller dose and over time, multiple dosing.
Fair. Okay, so my second question pertains to your follow-up in your cohort. So I noticed that you followed up with, I believe it was in your prospective cohort of 10, a median of 10 weeks. And I wonder if that time point was chosen strategically, and if you could achieve adherence to any specific time point, looking at the parameters that you did, is there an ideal time to be looking for these changes in platelet function?
Yeah, that's a very savvy question. So we sort of chose a time point that meshed. It wasn't necessarily based on what we thought would happen to platelets. It was more meshed on our clinical practice. So when I give patients IV iron, we do want to see that it worked. So I want to recheck their iron indices at some point. But when that is actually not super well described in the literature. It's not like on oncology where there's clear guidelines, like get a CT scan every 3 months. So numbers I've heard people quote, or just my experience with colleagues, is to recheck iron. And usually we check a ferritin as an accurate measure of how much iron a person has, somewhere between 6 weeks and 3 months after an infusion. And whenever you do a study that involves humans, you have to allow that wiggle room. It's a lot different than a benchtop study. So I believe when we made the consent form for the trial, we had allowed people that leeway to come in. But you're right in that what we didn't capture was how dynamic these changes are. And it's possible if we had measured at several time points, we would have found changes in the function. So I think that's an interesting question, something we would think about asking in the future.
Awesome. And now I have one more question for you. You mentioned that in your limitations that you were limited on the types of analyses that you can do in your cohort and your prospective cohort. So I'm wondering now, knowing what you know now and the changes that you saw in the platelets, is there one additional marker or parameter that could have been included in the analysis, or that you wish that you could have included in the analysis that may shed light on a specific question that you have now?
I mean, there's so much more I want to ask. So this study got us excited, and we've written a lot of grants around the concept. I think that I would probably first pass it over to Jamie, because we have actually designed some animal models, and that's really her focus, that sort of attempt to answer some of these questions, and then I can answer in what I would look at in my patients.
Yeah, I think that this really opens an area of a lot of potential for exploration, and really has a good place for a very translational preclinical model, really to dive into the mechanistic pathways and such that, in the human population with the different, varying degrees of iron deficiency anemia that might be influencing some of the results we got in the study. I think in using a primate model, which is kind of primarily my research background, we can more succinctly have control over experimental manipulation, so that potentially we can use a rhesus macaque model, which translates very well to humans. And especially if we want to eventually dive into that repro biology space and looking at how this might impact pregnancy, and really manipulate the degree of iron deficiency that the animals get to, so that we can more tightly investigate, some of these results that we saw in this study, whether or not it's first replicable in the primate model, and then second, if so, if we can more tightly regulate the iron deficiency anemia, are we able to still see the same findings in terms of, the low platelets with iron deficiency anemia, or was that a result of some of the other factors from the variability in women?
Yeah, I would agree with all of that. I would say if our hypothesis is true, and that is that when your iron is low, your platelets don't function as well, and you're more likely to bleed. That suggests that iron deficiency can cause this spiral where people just start losing more iron. And I think that is an important concept, if true, in women's health. It would suggest that we should be giving a lot more iron than we do. So personally, I think there's a lot of unanswered questions in measuring that. I think the models that Jamie designed could be really impactful in that regard. I think in the human question, there's a lot of ways that we can measure hemostasis, both in blood draws and then in clinical samples, that I hope we get the opportunity to do someday. And then I think if we answer this question, the other piece I'd like to touch on is, can we make iron repletion better? And one of the targets that we've been looking at is hepcidin, which really, the body is kind of designed to only absorb a small amount of iron every day. And hepcidin really prevents you from absorbing too much. This is a protective thing to prevent iron overload. But we've been very interested in targeting that to make oral iron work better. And that's one of the experiments we've been proposing lately. So I think those two pieces, how iron, what its role is in hemostasis, and then can we make better therapies for iron by manipulating the iron regulatory pathways? I think those are two really key questions we're hoping to answer.
And would really have a huge global impact on women's health, especially just given many other countries don't have access to IV iron.
Yeah.
Well, to come. Thank you, Dr. Schatzel and Dr. Lowe, for presenting your work and giving us some insight into the effect of iron on platelets, in patients with iron deficiency anemia. And I hope that these findings inform clinicians and researchers looking at this problem in the future. And we will definitely tune in and keep an eye out for your future work, as you have just detailed. And of course, the viewers can read all the details of this paper on our website at rpth.isth.org. Thank you all for watching, and thank you both for presenting, and keep an eye out for the next RPTH research recap.
Thank you.
Thank you.